Pediatric GI questions on Step 2 CK are built on a highly predictable matrix of strict chronological windows and pathognomonic symptoms. Identifying these specific patterns allows you to quickly sort all the varied clinical data points into specific diagnostic categories. The underlying pathophysiology follows a binary logic. It is either a congenital structural failure or an acquired vascular or inflammatory event. Congenital structural failures are errors in embryogenic development, such as the failure of the bowel lumen to recanalize or the aborted migration of neural crust cells. Acquired events are sudden physiological crises, where previously normal anatomy is compromised by telescoping bowel segments or vascular accidents that trigger immediate ischemia. Clinical mimics present a challenge because entirely different conditions share the exact same symptom, like bilious vomiting or delayed meconium passage. Separating these mimics requires finding a single distinguishing feature, such as the patient's hemodynamic stability or the specific consistency of the meconium. Mastering this chronological and symptom-based matrix provides the evidence needed to determine the precise next step in management. Consider the first chronological window, a neonate presenting within the first 48 hours of life with early bilious emesis. This introduces the first mimic pair, duodenal atresia versus jejunal or ileal atresia. While both cause bilious vomiting, their origins are distinct. Duodenal atresia is a failure of bowel recanalization and is highly associated with Down syndrome. This side-by-side comparison matrix isolates their diagnostic differences. On the left, duodenal atresia presents with the double bubble sign. On the right, multiple air fluid levels indicate jejunal or ileal atresia. This is caused by an in utero vascular accident that leaves behind blind ends of intestine. Because this atresia is the result of a vascular disruption, the primary risk factors are maternal vasoconstrictive exposures, such as tobacco or cocaine use. The most urgent mimic for early bilious emesis is malrotation with midgut volvulus. In volvulus, the small valve twists around the superior mesenteric artery. This rapidly cuts off blood flow, leading to gut ischemia and necrosis. Management changes immediately if the neonate becomes hemodynamically unstable or develops peritoneal signs. An unstable patient bypasses diagnostic imaging and proceeds directly to an exploratory laparotomy to prevent total bowel loss. The second major neonatal presentation is the failure to pass meconium within 48 hours of birth. Hirschsprung disease is caused by a failure of neural crest cell migration, leaving the distal colon aganglionic and unable to relax. This two-column chart compares Hirschsprung findings against its primary mimic, meconium ileus. Column 1 shows the narrow rectosigmoid and dilated proximal colon typical of Hirschsprung, which also features a positive squirt sign on exam. Column 2 shows meconium ileus. Here, the ileum is obstructed by thickened stool, resulting in a microcolon and a negative squirt sign. This condition is exclusively associated with cystic fibrosis. The anatomical level of the obstruction, combined with the presence or absence of the squirt sign, definitively splits these two mimics. In the toddler demographic, ages 6 to 36 months, acquired obstructions become more common than congenital ones. The primary concern is intussusception, where one bowel segment telescopes into an adjacent segment, most often at the ileocecal junction. This diagram shows the target sign on ultrasound and the corresponding treatment, reduction using an air or saline enema. This ultrasound is indicated when a toddler presents with sudden intermittent abdominal pain, a right-sided sausage-shaped mass, and current jelly stools. This telescoping is often triggered by post-viral hypertrophy of Peyer's patches, but it can also be caused by a pathologic lead point. A Meckel diverticulum is the most common pathologic lead point, especially in cases where the intussusception recurs. A Meckel diverticulum can also present independently as painless hematochezia in a young child. Diagnosis requires a technetium 99M per technetate scan, followed by surgical removal if the patient is symptomatic. If we look back to premature, low birth weight infants, we find a different acquired emergency, necrotizing enterocolitis, or NEC. NEC involves a dual threat: ischemic mucosal injury combined with gas-producing bacterial invasion that occurs after enteral feeds begin. Management follows a strict sequence. Immediately stop feeds, decompress the stomach, and obtain cultures before starting broad-spectrum antibiotics. The patient's age and specific triggers, like a viral illness in a toddler or the start of feeding in a preemie, reveal whether an obstruction is mechanical or inflammatory. Some conditions mimic surgical emergencies, but require strictly medical or nutritional intervention. Rye syndrome is an acute encephalopathy and liver failure that occurs when aspirin is used during a viral illness. In Rye syndrome, lab results show severe transaminitis and high ammonia, but the bilirubin levels typically remain normal. In cases of severe pediatric malnutrition, the body often lacks the cardiac reserve to handle sudden volume changes. Initial management must prioritize rewarming and cautious, slow rehydration, as aggressive fluid resuscitation can easily overwhelm a weakened heart. These severe cases are distinct from functional abdominal pain, which presents as chronic periumbilical pain with a normal physical exam and no red flag symptoms. When there are no peritoneal signs, abnormal imaging, or hemodynamic instability, the management algorithm shifts away from surgery and towards supportive reassurance. The key to management is recognizing exactly where medical supportive care ends and surgical intervention begins. This tree filters symptoms by instability or perforation. In the red pathway, unstable bilious emesis, intussusception with a rigid abdomen, or NEC with free air all require immediate laparotomy. Stable patients take the green pathway, enemas for intussusception, and bowel rest with antibiotics for NEC. This graphic summarizes the specific radiographic indicators, the target sign for intussusception, the double bubble for duodenal atresia, and pneumatosis intestinalis for NEC. Identifying these chronological patterns and imaging findings provides the exact evidence needed to select the correct next step in management.